This next patient is an 8-month-old male. He has no known allergies. He weighs 5.7 kilos. He has a pretty complex medical history, born a twin with pulmonary hypertension, a series of malformations defined as pentology of Cantrell, which includes diaphragmatic hernia, a displaced pericardial sac defect, skin-covered omphalocele, a sternal cleft, as well as a significant cardiac history including double outlet right ventricle, transposition of great arteries, a VSD, an ASD, and a pulmonary stenosis, all of which are unrepaired at this time. His recent procedure was a pulmonary valvuloplasty via cardiac catheterization, and that was performed in July of this year. The cardiac team decided that they would wait for him to grow, and due to his complex physiology, they would wait to determine a better plan for him to have a biventricle repair. This patient presents to us today with a 2-day history of fever at home. So Dad was taking care of him throughout the day. He was doing well, acting appropriately, no irritability, no difficulty with feeds, until that evening when he finished his bottle and had a projectile vomiting episode. Dad describes that there was no bile or blood in the emesis, but within the hour they immediately took him to the emergency room near their home. And at that time he had another episode of emesis, of projectile vomiting. Again, no blood, no bile. The team there went ahead and obtained blood cultures. He had a temperature of 38.9. They did blood cultures. They obtained a white blood cell count specimen. They attempted to obtain a urinalysis and a urine culture through a urine specimen, but were unable to do so. They administered a 10 per kilo fluid bolus, and they transferred him to our main campus and admitted him to the floor. At that time, they performed a chest x-ray in which it showed some small airway inflammatory process indicating a possible viral process infection. We also obtained a CRP to evaluate for an inflammatory process, and in addition to looking at the white blood cell count, his CRP was elevated to 4, his white blood cell count was 20, his neutrophil count was 11.9, and his blood culture on the 6th came back Streptococcus pneumonia, gram-positive cocci. The team went ahead and started him on a broad-spectrum ceftriaxone. He was receiving 50 per kilo per day, once daily. He's on day 2 of that. So we have been consulted as the infectious disease team to identify the source of his infection and to evaluate if there needs to be further recommendations while we wait for susceptibility on this blood culture organism to grow in the microbiology lab. After speaking with the family, I learned more that the child has a twin brother along with an older sister, none of which are sick or have been sick, no recent sick contacts in the home or in and out, no formal daycare. They have not had any recent travel outside the U.S. or within the United States. This patient had been relatively healthy despite his omphalocele and cardiac defects that have not been repaired. He was taking a bottle while at home. He has not had any increased work of breathing or irritability. He interacts appropriately. Parents described that they had not seen him having any sort of projectile vomiting like this in the past, so this was definitely new to them. He has a primary care provider and is up to date on his immunizations. We will double check in the system as well to confirm that those vaccines are in fact up to date. He has never had a history of a previous urinary tract infection. He's never had a history of an ear infection, although the parents were concerned that this time around he was pulling at his ears. The team examined him. His tympanic membranes were clear. There was no sign of an acute otitis media at this time. He is uncircumcised, and still they have not obtained a urine culture at this time. On physical exam this morning, he was appropriate. He was interacting. He was moving all extremities. He was tracking and focusing. His respiratory exam was within normal limits. His lung sounds were clear. No increased work of breathing. He was on room air. No difficulty from a respiratory standpoint. From a cardiac standpoint, heart tones, murmur was auscultated, systolic ejection murmur, as well as normal sinus rhythm. His perfusion he was warm, centrally and peripherally, +2 pulses, strong bilateral upper and lower extremities, brisk capillary refill, no concern with hemodynamics, blood pressures within normal range for his age this morning. The patient's abdomen, from a GI-GU standpoint, abdomen was soft, non-distended, bowel sounds were present. He was having wet diapers. Mom and Dad reported that he had 2 overnight. He is uncircumcised. As far as from our infectious disease standpoint, we would want to obtain a second blood culture to make sure that it is not a transient bacteremia, but this patient's blood culture on admission reported Streptococcus pneumonia. For this age population, we would presume that that is prevalent, and for any age child in the respiratory tract, but we would still want to obtain a second blood culture to see if it came back positive or if it was negative, what we would do from there, and continue to keep the IV ceftriaxone on board until that point. The other thing to consider with this child is his complex medical history and what may or may not be anatomically or physiologically different. That being said, he's had a previous ultrasound, abdominal ultrasound in the last month showing his presence of a spleen, but we would want to evaluate for function of splenic function. So for this patient, I would recommend another blood culture. I would recommend a peripheral smear to evaluate for hollow jolly bodies to assess for splenic function or functional asplenia. And in that case, that would render reevaluation of his vaccination process, and he would require additional vaccines after completing the PCV13 vaccine. He would need a series of a one-time PPSV23 vaccination if he had functional asplenia. So impression, again, this is an 8-month-old male with a complex medical history, presenting with 2-day history of acute fever and projectile vomiting with unknown source at this time. we have a blood culture that's positive with Streptococcus pneumonia, but we want to verify that with a second blood culture. Patient is clinically stable on exam, does not appear toxic or in acute distress. I would move forward with a second blood culture. I would reconsider a urinalysis and a urine culture and a peripheral smear with a second blood culture to evaluate for functional asplenia. This is an infectious disease consult patient. We provide the recommendations to the primary team. Ultimately, the primary team makes the final decision for this patient.